welcome Dr. Alexandre Abezaid from Sao Paulo, Brazil, who's also joined us. Let's go to our last talk. Dr. Ye from Beth Israel Deaconess Medical Center will talk about DAPT in 2021. I'm sure he's going to take us on a really nice ride about the real world implications. Dr. Ye. Can you unmute?
Thank you. Thank you, Dr. Moran. And Dr. Carney, I would agree that was far from a lay perspective. In fact, I'm a little bit at a loss for what to say after to follow that because it was so comprehensive, but I will persist nevertheless. These are my funding and disclosures, and you're going to hear a lot of similar themes to what you've heard in the past, and I'll try to put it into the context of what I feel are the real world implications. And my takeaway when thinking about the real world implications of the data that we have just seen are, and Dr. Moran was really clear about this, one size truly does not fit all. And so the challenge for us on a day-to-day basis is to figure out what size. And I think that is a challenge that we have some data to guide us, but ultimately it involves patient preferences as well as our clinical gestalt. Both bleeding and ischemia are important and they require careful assessment. After the procedure, I think we can think less about the stent than ever before. But paradoxically, during the procedure, I think we need to think more about the stent than we usually have in the past. So these are really the themes of the real world implications. And what we do, in so much of cardiology and interventional cardiology is navigate this narrow therapeutic window between ischemia on one side and bleeding on the other, represented here by this artist depiction of Scylla and Charybdis, the mythical creatures that Odysseus tried to sail between in the Straits of Messina. And so we're constantly navigating this narrow therapeutic window. And this is very difficult because the window is different for different patients. And so we not only have to navigate a narrow window, but we have to figure out who it is that which strategy belongs to whom. And this is favored in the guidelines. You saw this already in the prior presentations, that individualized treatment is actually codified in the guidelines with these Class 2B recommendations for shorter duration in high bleeding risk patients, for longer duration in high ischemic but low bleeding risk patients. It is also true for ACS patients. It's true in both stable ACS patients. It's true in both the US and the European guidelines. And so, and the 2x2s that you saw in Dr. Moran and Dr. Carney's presentations, really the challenge is that two of those, the sort of obvious buckets, the upper right and the lower left corners of those are really hard to find. Really what we're finding, mostly because bleeding risk and ischemic risk are so highly correlated, is a concentration of those difficult patients in the upper right corner, high bleeding risk, high ischemia patients, high ischemic risk, where we feel like, boy, we are really between that narrow rock and a hard place. You saw Dr. Carney speak about the HBR criteria, which I think were really an important step forward on really codifying and simplifying how we think about high bleeding risk characteristics. And I think these characteristics really have helped us conduct important clinical trials, evaluating stents and short dual antiplatelet therapy in such patients. It's important also to remember that there are validated scores to assess bleeding. There is the Paris bleeding score. Usman Baber with Dr. Moran made the Paris bleeding risk score in an all-comers population. So we're thinking about real world implications. To me, that is as real world as they come. There were anticoagulated patients in this group. There were patients who couldn't take DAPT for, very long at all before they had to bleed. And that's different than some of the scores that have come out of randomized clinical trials, including the DAPT score, which were cold populations who could adhere to protocol. So when you're thinking about that, the real world implications, it's important to think about what the study population that scores were derived from. The precise DAPT bleeding score and the Paris bleeding score both have similar characteristics. And what is true for bleeding in general is that even though these have been validated elsewhere and they perform, bleeding is just ultimately, it's hard to predict. It still remains hard to predict for the long term. You saw, I haven't seen this one yet, actually. This is Francesco Costa's analysis, which the reason why bleeding risk matters is because when we stratify patients by bleeding risk, we find that high bleeding risk patients really are the ones who benefit more for short duration therapy. And similarly, and sort of that it's the low bleeding risk patients, actually, and in this case, in the precise DAPT study, 75% would consider low bleeding risk. There was a clear signal for benefit for longer duration. So this is, again, this clear finding that one size truly does not fit all. You've seen the DAPT score before, you saw it previously, but it is among low bleeding risk patients, which is really the population of the DAPT study, that this is a way I think one can find those patients who are high ischemic risk, low bleeding risk, and the opposite among particularly those who you're thinking about a longer duration of DAPT for. And this was a tool that we think was able to sort of uncouple the risks of bleeding and ischemia. It is possible to go too short in acute coronary syndromes. In particular, here in the SMART DATE study, you saw that shorter duration of DAPT was associated with an increase in stent-related, myocardial infarction. In the interest of time, you've seen this already about coronary complexity. I'm going to move on and just talk about the fact that you can think less about the stent than ever before because of three important studies and more ongoing. First, a study, the Evolve Short DAPT study, extremely low rates of stent thrombosis here with the Synergy stent among a high bleeding risk population. Very similar results, extremely low rates of stent thrombosis among the Science 28 and 90 studies led by Dr. Moran. And then finally, the Onyx 1 global study. You've seen these graphs already, but I think the one really notable important thing about the Onyx 1 global study that Kate alluded to was the very real world population that was included in this study. And if you look at the stent characteristics, the stent length, the amount of calcification in these lesions, these were real difficult complex coronary cases that had extraordinarily low rates of stent thrombosis here with the Onyx drug-eluting stent in the randomized against leaders free. Against biofreedom. We should think more about the stent during the procedure in order to think less about it afterwards. And this is one area where we can think about how we can actually widen that narrow therapeutic window. I think that's what we're doing in the cath lab. The new stents actually make it easier for us to make DAPT decisions. We have less of a trade-off. And so what we can do in the cath lab is we should be doing more intravascular imaging to get better expansion, which we know is associated with better outcomes for the stent. We need better vessel preparation. People are still limited by concerns about their ability to do potentially atherectomy or other things that really should become more routine. High pressure post-dilatation, that needs to become mandatory. Post-stent imaging, all of these things, I think attention to detail to these types of things can help us widen the area between bleeding and ischemic risk and make it easier for us to think a little bit less about the stent afterwards. So in conclusion, the cliche holds true. Our intuition and the data tell us that there is really no one-size-fits-all for DAPT strategies. So identify each patient's best path between bleeding and ischemia. And there are the combination of validated tools that I've talked about in addition to careful clinical assessment that involves patient preferences. I think what an achievement for modern stents that have really helped facilitate this decision by reducing the ischemic penalty for shortening DAPT duration. And during the procedure, we need to do our part as interventional cardiologists, maximizing procedural outcomes through what I think is the new standard of care, which involves careful prep, vessel prep, imaging, post-dilation, and then imaging again. Thanks very much.
Thank you, Dr. Yeh. That was really fantastic.